Hello, everyone. My name is Jose Francisco, Project Manager at the IAS-USA. Today's webinar will be providing an update on treatment for mild to moderate COVID-19. I'd like to welcome today's speaker, Dr. Kara Chu, Associate Clinical Professor of Medicine at the University of California, Los Angeles. Welcome, Dr. Chu.
Thanks very much, Jose. So thank you all for joining. So we will go over today treatment for mild to moderate COVID-19, which is really treatment in the outpatient setting for those individuals that don't require hospitalization for COVID-19. So we're going to take care of a few housekeeping things first. The IAS-USA designates this live activity for a maximum of 1.25 CME credits. And the webinar is also approved for 1.25 hours of ABIM MOC points and nursing, pharmacy, and pharmacotherapy credit. So instructions for claiming credit will be emailed to you, so look for that after the webinar. Generous support for this activity has been received from these contributors listed here. So some tips for navigating the webinar. There will be some poll questions, and for these, a separate window will show. Choose your response, and then we'll see the responses displayed after the poll closes. I will take some questions in a Q&A session after the talk, and to submit questions, use the Q&A button, and you do have to indicate your first and last name in order to have your questions addressed, and hopefully we'll get to most, if not all, of your questions at the end of the webinar. So here's the first poll. Currently, how involved are you with COVID-19 medical care? Please provide your response. Okay, so it looks like the majority are not at all or somewhat involved. And poll number 2, currently, how involved are you with COVID-19 research? Okay, and mostly not much involved or not at all involved. Okay. So just a summary here of my disclosures, which are research funding. And our objectives today are to describe the available therapies for the treatment of outpatients with COVID-19, to describe the latest recommendations in COVID-19 treatment guidelines for outpatients with COVID-19, and to describe the potential impact of SARS-CoV-2 variants on the effectiveness of monoclonal antibody therapies. Here's pretest question number 1. Which of the following currently has or have emergency use authorization from the U.S. Food and Drug Administration and is or are recommended by NIH guidelines for the treatment of COVID-19 for persons not requiring hospitalization? 1, hydroxychloroquine, 2, bamlanivimabletesevimab, 3, Casirivimablimdevimab, 4, Ivermectin, or 5, both 2 and 3. Okay, so this is a very well-informed audience. That is the majority of you got this question correct, which is number 5, that bamlanivimab and etesevimab and Casirivimablimdevimab have EUAs and are recommended. Okay, and then true or false? All available monoclonal antibody therapies are expected to be less active against all SARS-CoV-2 variants, and examples of those variants include B.1.1.7 and B.1.351. Okay, great. So yes, the variants have been a recent wrench in our management of COVID-19, and I'll go over the variant data. and the activity of the monoclonals during this talk. Okay, so diving in, I think you're all well aware of the burden of COVID-19 globally. And this is a little bit of an older slide. This is from April 9th, but an enormous burden globally with almost 3 million deaths reported worldwide. So definitely a need for interventions to prevent serious disease and also to prevent transmission. This is a summary of trends in new cases from the Johns Hopkins Coronavirus Resource Center as of April 9th, 2019. And it just shows new cases over time in the current most affected countries, 7-day moving average, and the different countries are represented in different colors. You can see the different peaks in the epidemic or pandemic over time in each of the countries. And so this continues to be a problem that we are all well aware of with ongoing new cases. This slide summarizes COVID-19 cases, hospitalizations, and mortality by race and ethnicity, and it's really meant just to highlight what we are well familiar with at this point, that there are disparities in case rates and in poor outcomes related to COVID-19 by race and ethnicity, with all of these metrics being increased compared to white persons amongst Blacks, Hispanics, and American Indian and Alaskan Natives. And so what underpins some of these differences may be socioeconomic status, access to healthcare, and potentially also risk of exposure related perhaps to like occupation. And so these are disparities that we really do need to mitigate in some way. All right, so this is a schematic of the course of SARS-CoV-2 infection over time. And what you can see here is first a period without symptoms where the viral load is increasing. At this point, there's a significant transmission potential, even in the absence of symptoms, as that viral load increases. And at this point, little inflammation. And as the course progresses, some individuals develop symptoms. The viral load actually starts to decline reliably in everyone, and there may be increasing inflammation and again, decreasing transmission potential. And then the risk of hospitalization really occurs around this point, which is around 10 days. 10 to 14 days. And then the mortality risk really comes following that as inflammation increases, and that inflammation and immune dysregulation mediates the more serious complications. And for some individuals, there continue to be some blips, and you can see by the dotted line, this is where the antibody response arises. And so in terms of thinking about interventions for COVID, when we look at those who are already at risk for hospitalization or hospitalized, at that point, there's a significant risk of dying. And really, we need an intervention earlier than this. So in the period early where individuals don't have symptoms, an intervention here would prevent disease and transmission. And at this point, where individuals have symptoms, milder symptoms, don't yet need hospitalization, an intervention here would help to speed recovery, prevent complications, severe disease, and also reduce transmission. So these are data summarizing mortality, in-hospital mortality. And this is just meant to highlight that once individuals are hospitalized, there is still a significant risk of death, while that has improved over time. So over a 5-month period from March 2020 to August 2020, the in-hospital mortality in US centers, and this is from about 550 centers that contributed these data, the in-hospital mortality went from 22.1% to 6.5% in August of 2020. And that's demonstrated here, where you can see over time with each line here being a different month of admission for the calendar year of 2020, that there were improvements in the survival probability over time with COVID, but still significant mortality risk once hospitalized. And the figure on the left is just showing in-hospital mortality by age group, which, as expected, increases with increasing age. So what are the current treatment options for outpatients with COVID-19? And are there any FDA-approved agents for COVID-19 for outpatient treatment? So this audience is pretty familiar with the available treatments. And the answer to are there any FDA-approved treatments is no. There are agents that have received emergency use authorization from the FDA, but this is not the same as FDA approval. These agents are still considered investigational. And so those agents are bamlanivimab, 700 milligrams given IV once, bamlanivimab 700 milligrams, and etesevimab 1400 milligrams given IV once, and Casirivimablimdevimab 1200 milligrams given IV once. So what is the bar for receiving an emergency use authorization? And really the standard is that the known and potential benefits of the investigational agent outweigh the known and potential risks. So what we're accepting here is that there is not a large safety data set for these agents, or at the time that the emergency use authorization was issued, but that the potential benefits are evident, and that those benefits outweigh what's unknown about safety, really. And in terms of benefits, what they're really looking for at this point is hospitalizations, a benefit in hospitalizations and deaths. So what are monoclonal antibodies? They are mimics of natural human antibodies, and for the most part, these monoclonal antibodies were identified and isolated from individuals that recovered from SARS-CoV-2 infection. And so they screened the B cells of these individuals and identified antibodies that were highly neutralizing against SARS-CoV-2, and then reproduced those in a lab. So mono meaning one and clonal meaning many, of course, as you all know. And these antibodies target the SARS-CoV-2 spike protein, and they are different from each other. They target different epitopes on the spike protein, and largely target the receptor binding domain of the spike protein, which is the region that interacts with the ACE2 receptor on the human cell, and facilitates SARS-CoV-2 entry. So the antibodies represented here in green in these Y-shaped figures, and here in red is the SARS-CoV-2 spike. They'll bind this in this graphic. They'll bind the spike protein and prevent interaction with the ACE2 receptor, and then prevent entry of the virus into the cells. And there are antibodies that are also target regions other than those in the receptor binding domain that directly correspond to the ACE2 target. So the antibodies bind to the virus and they prevent the entry of the virus in the cells, and so that's may prevent in that way the spread of infection. And some antibodies may also facilitate viral clearance. So what are the data that underpin the emergency use authorizations that were issued? So first we have bamlanivimab. So that was the very first one that an EUA was issued for. And these were the first published data from an interim analysis. And bamlanivimab was given in a range of 3 doses, 700 milligrams, 2,800 milligrams, and 7,000 milligrams, or placebo. So they were randomized. And you can see the sample size for each arm: 101, 107, 101, and 143. So overall, a relatively small sample size at this point. This was published in October 2020. And for this study, the participants had to have a positive SARS-CoV-2 test within 3 days before randomization or infusion, mild or moderate COVID-19 symptoms, and the primary endpoint was change from baseline to day 11 in the SARS-CoV-2 viral load. And so this was all designed in the very, very early days of COVID. And there was a lot of uncertainty at that point about what would be appropriate endpoints and time points at which to assess changes in viral load. Other secondary endpoints included safety, symptom severity, hospitalization, and looking at different time points for viral clearance. So here are the data from that study, from this interim analysis of BLAZE-1. And in this figure, what's shown is the mean change from baseline in viral load at day 11. So for each individual, change from baseline, day 11 minus baseline. And here we have the change in the bamlanivimab arms, and then the total, they pooled for some analyses, the 3 doses. And then here, the change for placebo. And then given below that are mean changes from baseline and viral load at different time points, at the earlier time points. What you can see is that for the most part, there was not actually, this primary outcome was not met for, if you just looked at the individual doses, except for the 2,800 milligram dose, where there was a significant difference compared to placebo in mean change from baseline and viral load at day 11. And then looking at this figure, this was an interesting figure where what's described is a cycle threshold for the SARS-CoV-2 RNA at each of the different days. And they differentiated between those who are non-hospitalized in these box plots, and then the individuals who are hospitalized in these red dots. And so cycle threshold reflects the real-time PCR method. This was not actually, in terms of the SARS-CoV-2 RNA testing, a really quantitative assay that was used in this study. But cycle threshold generally will correspond to viral load, where a lower cycle threshold, a smaller number, reflects a higher viral load. So it reflects how many cycles of amplification through PCR are needed to detect virus. And so the smaller the number, the fewer the cycles to detect virus, reflecting more virus present. And so you can see over time, the cycle threshold increased. So the viral load decreased over time across most of the participants. But what the pattern that is somewhat evident here is that for those individuals who are hospitalized, their viral loads at each time point tended to stay up. And so this may be a marker or a predictor of individuals who end up needing hospitalization. So just key things to take to be aware of for this study and for the treatment with bamlanivimab here. Individuals entered with a median of 4 days of symptoms and were treated at a median of 4 days. So that's relatively few days of symptoms at the time of treatment. And altogether, bamlanivimab did appear to reduce the viral load faster, particularly looking at the pool doses. And then looking at hospitalizations and ER visits, 1.6% versus 6.3% of events was observed in the bamlanivimab versus the placebo groups. And so it was this difference in hospitalizations and ER visits that led to the EUA. So a relative reduction of close to 70% in hospitalizations and ER visits, and this was a secondary outcome. So then a subsequent publication included a combination of bamlanivimab and etesevimab. So these are basically the same data for the other treatment arms, the 3 doses of bamlanivimab alone. And then what was introduced was this combination given 2,800 milligrams of each dose, of each monoclonal antibody. And I just want to point that out because you'll note that this is not the dose. So this is the dose that was studied and published here, but it's not the dose that was given the EUA. So for the EUA, the dose is 700 milligrams of bamlanivimab and 1,400 milligrams of etesevimab. So really looking at these later time points, day 7 and day 11, what you can see with the blue bars, which represents the combo treatment, is that there does appear to be a more significant reduction from baseline in viral load, or here log viral load, with the combo as compared to the bamlanivimab monotherapy arms and compared to placebo. And looking statistically at the differences in change in log viral load at day 11 compared to placebo, that difference was significant only for the combination arm here. So combination therapy does seem to be proving to be more effective than monotherapy. All right, and so just from that same study, these are the cycle threshold curves over time for the different arms and for including this additional combination arm. And what you can see here is that there is a real there seems to be a more dramatic decline in bamlanivimab with the combination in the cycle threshold value, or I should say increase in the cycle threshold value over time compared to the other treatment arms. And I just wanted to highlight here the number of events that was observed in each treatment arm for hospitalizations and ED visits, and these were specifically COVID-related hospitalizations. And they are generally small, as the sample size was small for these arms in this study. So just 9 events in the placebo group out of 156, and 1 or 2 events in each of the active treatment arms, with the proportion with this outcome given here. All right, so in these studies, the majority, but not all participants had risk factors for progression to severe COVID-19. Okay, so then moving to phase 3 data. Sorry, there's a little typo there. This was just presented at CROI 2021, and this is phase 3 data of bamlanivimab and etesevimab at those 2,800 milligram doses. So the sample sizes here of 517 and 518 for placebo versus active treatment. So a more robust evaluation, and here all the individuals had some risk for severe COVID. And the COVID-19 related hospitalization or any cause death through day 29 of follow-up was 7% in the placebo group and 2.1% in the BAM-ETI group. So that was a 70% relative reduction compared to placebo. You can see the difference in the curves here in terms of the proportion of participants meeting this outcome. And a lot of those events are really happening pretty early in the first week or week and a half or so. So further evidence to support that bamlanivimab and etesevimab given for early COVID has a significant benefit in reducing hospitalizations and deaths in individuals with risk factors for COVID progression. All right, so then moving to Casirivimablimdevimab, the other combination with an EUA. These are the phase 2 data that contributed to the initial EUA. This was also an interim analysis published in December of 2020. And here they looked at 2 doses with 90 and 93 per arm and randomized to placebo as well. And the median symptom duration at randomization or treatment was 3 days here, so also early in the course. What was allowed was up to 7 days of symptoms. And there was a primary virologic endpoint, and then also as a key clinical endpoint, medically attended visits. So that was really any visit to any for like healthcare, to in any healthcare setting, urgent care, EDs. This could also include hospitalizations. And so here, looking at the viral load over time in the overall population, you can see a separation in the change in mean viral load from baseline in the two active treatment arms, the two doses of this combination monoclonal compared to placebo. And these differences were more obvious, more dramatic, with higher viral loads at study entry. I don't have that data here. And then they did do baseline serologic testing in all individuals, but that did not influence the initiation of treatment. And pre-specified was actually looking at the antibody negative group in the first primary efficacy analyses. And what you can see here is that those who were antibody negative appear to have a more dramatic benefit in terms of antiviral effects with the active treatment compared to placebo, and that's less observed in those who came into the study antibody positive. All right, and in terms of those medically attended visits, there were more in the placebo group compared to the two dose arms combined, 6% versus 3%. Okay, so here are then phase 3 data that have not been published, but were shared by Regeneron. And so what we're looking at here are COVID-related hospitalizations or all-cause deaths through day 29. And all these individuals, so while in the phase 2 data, the majority of individuals had risk factors for COVID progression, in this case, all participants had to have some risk factor for COVID progression, and that could include age, I think 50 or older, or a comorbidity. So this analysis data set represented by MFAS, what that actually means is that they restricted the, and this was pre-specified, the primary analysis to those who actually had detectable virus on NP swabs collected at randomization. So while a positive viral load or positive SARS-CoV-2 RNA was required within a few days of study entry, some individuals will end up not being positive at the time that they actually start the study and are dosed. And so this was restricted to those individuals. And the two different doses that were studied are given here. And what we see here is something very similar to what was observed with the bamlanivimab and also bamlanivimab alone in that early data, which is a relative reduction in hospitalizations or deaths of about 70%. And this is similar with the two doses, 70% and 71% compared to placebo. So very consistent findings in terms of the benefits on hospitalizations and deaths. And then looking at different subgroups, high viral loads at baseline, lower viral loads at baseline, the benefit is more obvious in those with high viral load at baseline, but the sample sizes are getting a little bit smaller here, which really extends the confidence intervals. And then again, looking at baseline seronegative versus baseline seropositive, those benefits seem to be potentially, as far as these point estimates, even greater compared to the overall group amongst those who were seronegative, but still benefit as far as the point estimates here in terms of those who came in baseline seropositive, but not significant here for this subgroup for 1200 milligrams versus placebo, but also small sample size, widening that confidence interval. So accumulating data, all very consistent on the benefit of combination monoclonal antibodies on hospitalizations and deaths. And then I just wanted to take a look at the virology here and see, what can we learn from the virology? So looking at in these first couple rows, so these are all participants. And then what we have in each row is, those that did not end up hospitalized or dying, and those that did, yes here, so 61 with hospitalization or death. And then what's given are the baseline and day 7 SARS-CoV-2 viral loads. And so what you can see is for those who are hospitalized, they tended to have higher viral loads at baseline. There's no statistical comparison here. And that viral load also tended to stay a little bit higher at day 7. So less of a reduction in viral loads. And then looking at the seronegative group, no hospitalizations, those who did not get hospitalized or die here, those who did here, we're seeing something similar, which is viral loads that stay higher at day 7 with less of a reduction from baseline to day 7 compared to the seronegative. And then amongst the seropositive, still a similar pattern amongst those hospitalized viral loads that are higher and stay a bit higher. And so there's a suggestion here that while these individuals were seropositive, that perhaps there was sort of an ineffective antibody response that contributed to the persistence of higher viral loads. So an emerging story. Okay, so who is eligible for the EUA MABs? This is from the bamlanivimab EUA fact sheet, but it's exactly the same for the combination regimens. And so the key is that these have to be individuals that are not hospitalized. There is no benefit observed with the addition of monoclonal antibodies on top of remdesivir in several studies to date. And that includes individuals who are requiring oxygen. So I mean that to be eligible for the EUAs, one cannot meet indication for hospitalization or have an increased oxygen requirement from baseline. The EUA is also indicated for those within 10 days of symptom onset, so earlier on in the disease course. The individuals must have some risk factor for progression to severe COVID-19 and or hospitalization, and that's defined in the EUA as patients who have a BMI of 35 or higher, have chronic kidney disease, have diabetes, have immunosuppressive disease, are currently receiving immunosuppressive treatment. This is at any age, and then any age 12 or older, and age 65 or older alone meets high risk criteria, and age 55 with cardiovascular disease, hypertension, or COPD. And for those 12 to 17 years of age, they have to have select comorbidities. So I just wanted to clarify that these are the criteria really for adults, and these are the criteria for those 12 to 17. Okay, so one major issue with the EUA MABs is the implementation of them. So there have been a number of headlines in the news over time. This is an earlier one from December. This is one that just popped up in the last couple of days. So the challenges that I've observed to implementing emergency use MABs have included identifying or setting up facilities to actually administer an infusion, and not just administer an infusion, but administer infusions to COVID positive patients. So there are infection prevention concerns to be aware of, transmission risks that have to be addressed. So this often means setting up logistically new infusion centers or infusion sites. There also needs to be adequate staffing, and that staffing includes staffing to administer an infusion and to manage potential infusion reactions, which are like allergic or hypersensitivity type reactions or cytokine release type reactions, which are generally uncommon. And then the MABs are indicated for those who are within 10 days of symptom onset. So what does that require? That requires really rapid and available SARS-CoV-2 testing to diagnose an individual. And then from there, rapid linkage to treat early. And because what we're really observing is that earlier treatment, even earlier than 10 days, like far less than 10 days, is preferable. And so how do you connect an individual who's diagnosed, who might not already be linked into care, to monoclonal antibody treatment sites? And then there's also the requirement for the time for infusion. The length of the infusion is anywhere from 20 minutes to an hour, followed by an hour of monitoring. And so that alone takes up time and limits the number of individuals that can be treated per day with these IV mAbs. And then there's also generally still a lack of awareness of the mAbs, of the evidence for the mAbs, and of the availability of the mAbs, and how to access the mAbs. And this is, I think, both on the provider level and on the patient level. So there's still a need to identify effective therapeutics that can be given more easily, but the evidence is pretty clear at this point on the benefit of the mAbs. Okay, so now we move to the variants, and this is a threat to treatment, a threat to diagnostics, and a threat to the the ending of this pandemic. All right, so these are some headlines about the variants sweeping the world, leading to another wave in Brazil. And this summarizes the SARS-CoV-2 genome and the virion structure here with the spike and RNA here, the associated nucleocapsid. And this is just meant to reflect, how the wild-type virus changes, which originate with RNA mutations in the gene of the spike for the spike protein, but these then lead to these RNA mutations then lead to spike mutations. And so one thing I want to describe is that actually we've been living for a while now with a variant. So this is a phylogenetic tree showing the evolution of SARS-CoV-2, and with these branch points, you see the variants that have emerged over time from the ancestral strain. But we have lived with D614G, which is a mutation present in spike across, that's present in almost all the circulating SARS-CoV-2 variants at this point. And that mutation is associated with increased transmissibility. And going back to this structure, a change in the spike conformation, spike protein conformation to an open conformation, which facilitates binding and potentially stability of the spike protein, and thus enhancing transmission and infection. And so from this ancestral strain, you see these variants that have evolved over time, and that we hear a lot about now: B135, originally identified in South Africa; B117, originally identified in the UK; P1, identified in Brazil, and in California, what's becoming the predominant strain, B1427, B1429, and there are others. So this is a summary from the CDC of variant frequency in the US. And you can see over time the increasing proportion of variants like B117. And this is from March 17th. And this has changed even from then. So just 10 days later, what was reported is that B117 was not just 9.9% of the viruses that have been sequenced, but 44%. So rapid evolution in the distribution of variants amongst those in the community. And we really need increased surveillance and sequencing to understand the prevalence, the true prevalence of the variants in our regions. And just to point out the other variants of concern like B1351 and P1, these percentages, the frequency of these variants has also inched up over time. Okay, so this table summarizes some of the things we know about some of the variants of concern. And what's highlighted in this row here are hallmark genetic changes, some of which are associated with increased transmission, and others that are associated with impacts on monoclonal antibody therapy. And so those that have more impact on the monoclonal antibody therapies are E484K, L452R. And so what matters almost more than the variants are the mutations as far as their impact on treatment options and on transmission. And 501Y has an impact on transmission. It's a marker of increased transmission risk. And then the 6970 deletion is actually a marker that could affect diagnostics as it leads to an S gene dropout. And that S gene is a target for SARS-CoV-2 diagnostics. And so for B117, we see increased transmissibility, also data now on increased mortality and severe disease for all these variants of concern. And that's why they are variants of concern: increased transmissibility and potentially reduced antibody neutralization through monoclonal antibody therapies or convalescent plasma. So what do these terms mean? Variant of interest, variant of concern, and then variant of high consequence. So there are classifications and definitions on the CDC website that you can peruse. And a variant of interest is essentially one that has markers that are predicted, genetic markers, those mutations that are predicted to affect all those elements that impact the state of COVID management, medical management, so and public health considerations, so these genetic markers, these variants of interest have specific genetic markers that are predicted to affect transmission, diagnostics, therapeutics, immune escape, disease severity, and there may be limited prevalence or expansion in the US or in other countries, and there could be evidence that they are a cause of an increased proportion of cases or unique outbreak clusters. And so variants of interest right now, those that are categorized as variants of interest are this variant that was identified in New York, B1527, and others B1525 and P2. And then variants of concerns are the ones that not only have these genetic markers, but have clear evidence of an impact on and these areas of interest: diagnostics, treatments, vaccines, transmissibility, and disease severity. So variants classified as VOCs at this point are B117, B1351, P1, and B1427, And thankfully, we do not yet have a variant of high consequence. And so those would be variants where there's evidence of significantly reduced effectiveness of prevention measures or medical countermeasures. All right, so how have SARS-CoV-2 variants affected treatment options? So significantly. So here we have for each of the monoclonal antibodies that has received an emergency use authorization, basically pseudovirus neutralization data. So first for bamlanivimab, and for these variants, in pseudovirus neutralization assays, these mutations were tested. So these are not neutralization assays using the whole live virus, but pseudoviruses looking at specific mutations or combinations of mutations. And so these are the mutations that were tested. And you'll recall that I mentioned that the key ones that have an impact on monoclonal antibody activity are E484K and L452R. And here you see that there's a marked impact on susceptibility to the mAbs in these with these pseudovirus neutralization assays with bamlanivimab. And so, but no change, and no change is defined by less than a twofold reduction in susceptibility. No change for the B117 variant where N501Y was tested as the mutation of interest. And so, so bamlanivimab would have expected retained activity against B117, but would be expected to really not be as effective against these other variants. And one key thing to note is that these are in vitro data, and we do not have clinical data to correlate the in vitro findings with clinical outcomes. So moving then to bamlanivimab and etesevimab, so this is a combination. And because these antibodies have different targets on the spike protein or receptor binding domain, then it makes sense that having using a combination more than one antibody with different targets would help overcome any reduced resistance or issues with reduced susceptibility with a single antibody. So here, what we see is something better than with bamlanivimab, still retained activity against B117, but significant decreases in activity or fold reductions in susceptibility to B1351 and P1, and lesser degrees of reductions in susceptibility to B1427 and 1429 and B1526. So, we really don't know what this means for clinical efficacy, but certainly concern for the combination with B1351 and the P1 variants. And then for Casirivimablimdevimab, here we see no significant change in susceptibility in these pseudovirus neutralization assays for all these variants listed here. And we only have the data, we only know for the variants that we test, but these are the major variants of concern or interest at this point. So variable activity expected across monoclonal antibodies, except for with B117, a retention activity expected across all of them. And this is certainly consideration when you're looking at the variants that are circulating in your community and that may be impacting your selection of a monoclonal antibody for treatment. Okay, so with that data, with the in vitro data, and this concern of the activity of bamlanivimab, in early March 2021, and I'm not exactly sure when this was, it was March 11th or prior to that, there was an initial warning issued by the US Department of Health and Human Services that the clinical activity of bamlanivimab could be impacted by a variant that was observed to be circulating in the United States, the B1429-427 variant. And so this warning was issued, and distribution to these regions was actually limited. And at that point, that action only affected California, Arizona, and Nevada. And then not too long after that, March 24th, it was determined that bamlanivimab as a monotherapy would no longer be distributed because of resistance concerns. So very rapid evolution of treatment from even the monoclonals becoming available to now the significant concern for activity with for their activity with new variants. So what are the treatment guidelines? What are the recommendations? These recommendations are updated very frequently, so I would revisit them often. But these are the NIH COVID-19 treatment guidelines, and there are two sets of guidelines: the NIH guidelines and IDSA guidelines. Here, these guidelines were last updated April 8th. And the NIH COVID-19 treatment guidelines panel recommends for those who meet EUA criteria for being at high risk of clinical progression with mild to moderate COVID who are not hospitalized, they recommend the two combination monoclonals, bamlanivimab 700 plus etesevimab 1400, and Casirivimab 1200 plus imedevimab 1200. And the recommendation is to start as soon as possible, but within 10 days of symptom onset, as are the requirements too of the EUA. So one thing I wanted to highlight, which I just touched on, is that with the in vitro susceptibility data, where there may be more retained activity across the variants for Casirivimablimdevimab, there are some experts who would favor Casirivimablimdevimab over bamlanivimab and etesevimab in those regions where the variants that are most impacted are more frequent. So, but again, acknowledging that we don't really know how or if the in vitro susceptibility data correlate with clinical outcomes, but I think it's reasonable to consider this. Okay, and then consistent with the halting of distribution of bamlanivimab, bamlanivimab monotherapy is no longer recommended. And then these are the IDSA COVID-19 treatment guidelines, and they were just recently updated April 14th, also to suggest the use and support the use of the two combination regimens for high-risk individuals with mild to moderate COVID-19. Also note there are no head-to-head data for the two combinations. Okay, and very recently now, just a few days ago, the FDA revoked the EUA for bamlanivimab. So bamlanivimab should absolutely not be used at this time. And actually, I think the company requested this withdrawal. Okay, so what then are the treatment options for those with COVID-19 who don't qualify for EUA-MAB? So these are those individuals who don't have the high-risk characteristics for COVID progression, and who don't meet perhaps the symptom duration criteria. So there are really no available options at this point. There are no FDA-approved therapeutics. There are no EUA therapeutics other than the monoclonals. But there are a lot of agents being studied. One thing that is clear from the guidelines is that they recommend against the use of chloroquine or hydroxychloroquine with or without azithromycin. They recommend against the use of lopinavir or ritonavir and other HIV protease inhibitors. And the position is that there are insufficient data for or against ivermectin, and that clinical trials are needed, and also insufficient data for or against the use of these other like supplements, vitamins, vitamin C, D, and zinc. There are a number of therapeutics in the pipeline. What's listed here are largely ones that are really considered on some level to be antivirals. Numerous polymerase inhibitors under investigation, protease inhibitors, entry inhibitors. So these include like the monoclonal antibodies. There are also polyclonal antibodies. Convalescent plasma would follow here, and other antibody-based or other therapeutics that impact entry or virus attachment. And then interferons, which are non-specific antiviral, and then host-targeted therapies that are felt to potentially have an antiviral, potential antiviral mechanism, and more. So I'll review some of the data available for these other agents under investigation. So molnupiravir, or MK-4482, and formerly EIDD-2081, is an antiviral that is not specific to SARS-CoV-2, has that potential activity across a number of viruses, and it's thought to exert its effects through viral mutagenesis, and then basically like catastrophic errors in that then decrease viral replication. And we don't have any clinical outcome data. These data were presented at CROI 2021. And what they saw looking at viral cultures was a significant reduction in positive viral culture, so really reflecting infectious virus at day 5 in those who received molnupiravir compared to placebo. And there was a numerical difference observed at day 3, but that was not significant. So this was there were a total of 182 non-hospitalized adults that were evaluated with less than 7 days of symptoms, and there were several doses of molnupiravir that were studied. And this is an oral agent given for 5 days. So we will look forward to symptom or other clinical outcome data. Ivermectin, there's been a lot of interest in ivermectin. There are a number of clinical trials evaluating ivermectin. So this is an antiparasitic that is thought to have an antiviral effect against SARS-CoV-2. In this RCT that was placebo-controlled and blinded, the primary outcome was symptom resolution, or time to first day free of symptoms reported by the participants over 21 days of follow-up. And there was no difference observed in time to resolution of symptoms in this population. So we will have to await more data on ivermectin. Here's some data on convalescent plasma for early COVID-19. Now, this study here looked at older individuals, 75 or older, or 65 to 74 with a comorbid condition, and very early on in their disease course, less than 72 hours of symptoms. They used a high titer of convalescent plasma, greater than 1/1000 against spike protein, and the primary outcome was severe respiratory disease, which was defined as a respiratory rate of 30 or more breaths per minute and or an O2 sat of less than 93% on room air. And they found a significant benefit in terms of progression to severe respiratory disease with the relative risk reduction here, the relative risk was 0.52 compared to placebo with convalescent plasma. So, I think key things to take from here is that the treatment was given very early, a high titer was used, and so there may be benefit with early treatment with convalescent plasma. Now, there was a separate large NIH-funded clinical trial of convalescent plasma for outpatients, broader population, longer symptom duration, and that study was in February, I believe, terminated early for lack of benefit, and they used a lower titer of convalescent plasma. Now, fluvoxamine, there's a lot of interest in fluvoxamine. This is an SSRI. It may have immunomodulatory effects and also potentially have some impact as an antiviral, at least considering host-dependent factors for SARS-CoV-2 replication. And in this study, fluvoxamine, this is an RCT again, fluvoxamine given compared to placebo in participants with symptom onset within 7 days. They looked at dose titrated up to 100 milligrams TID for 15 days, clinical primary outcome of clinical deterioration. And here there was a significant difference benefit with fluvoxamine, where 0 out of 80 of the fluvoxamine and 6 of the 72 placebo participants met this clinical deterioration endpoint. and that was statistically significant, absolute difference of 8.7%. So definitely intriguing, but a small sample size, and more studies coming. Okay, other approaches and mostly antiviral to treating outpatient acute COVID-19 that are under investigation. Inhaled steroids. There have been some recent data shared on inhaled budesonide, and also that where there's potential benefit in a phase 2 study or an interim analysis. And then colchicine. And then there's a significant interest in anticoagulation antithrombotics. So Active 4B is an NIH-sponsored trial looking at lower, higher dose apixaban versus aspirin versus placebo in a primary cardiovascular pulmonary-based outcome. And then just announced is Active 6, which is another trial, adaptive platform trial coming out of the, platform trial coming out of the active public-private partnership. And this is a study of repurposed drugs for outpatients. So this is going to be a phase 3 RCT for individuals with less than 7 days of symptoms, 30 years of age or older, and the primary outcome will be symptom reduction. So this trial hasn't started yet, but it will study a number of drugs, repurposed drugs for COVID-19 benefit in outpatients. All right, and I wanted to mention Active 2, which is a trial of outpatient therapies for COVID-19. I'm a co-chair of this trial, and for this trial, we are looking at a number of different therapeutics for early COVID treatment. Eligibility-wise, participants need to be symptomatic for less than 8 days, and we're going to be moving to 7 days. SARS-CoV-2 positive and 18 or older. And in terms of the therapeutics under investigation, right now compared to placebo, we have combination monoclonal antibodies given IV intramuscularly and coming subcutaneously. And these monoclonals have retained activity appear to have retained activity against the variants. Polyclonal antibodies also with good activity in vitro against the variants. Interferon beta that's inhaled, and also a host serine protease inhibitor pill given orally. So, I think what we need still are effective therapies, and we need rigorous trials to really determine the safety and the efficacy of different therapeutics. And I would really encourage everyone to refer their patients who don't qualify for an EUA to clinical trials for this, really the benefit of all of us to try to identify more therapies that can be given more easily, that are scalable and effective. And so for Active 2, we have a website, riseabovecovid.org, and individuals can go there and learn more about the trial, and also provide some preliminary information and get connected to a call center or call directly this number here to be connected to the closest study site if they are potentially eligible. All right, so we're back to the questions. They're post-test questions. Which of the following currently has or have emergency use authorization from the FDA and are recommended by guidelines for the treatment of COVID-19 for those not requiring hospitalization? All right, so that's great. That's correct. The majority of you now have answered correctly that bamlanivimabletesevimab and Casirivimablimdevimab are the agents that have EUAs that are recommended. Okay. And then post-test question 2. Okay, excellent. So the key here is really that there is still retained activity for the monoclonal antibodies against B117, but there is variable activity for the other variants, depending on the monoclonal. Okay, I just want to acknowledge a couple colleagues who shared some virology related slides with me, and point you to these resources. So the bottom two here are the treatment guidelines, and then combatcovid.hhs.gov. This is a resource for patients and clinicians. I think it is helpful because one of the issues is really trying to link up sometimes with a center that that is offering monoclonal antibodies, and so this website provides assistance with that linkage. Okay, so we'll move on to Q&A, and I'm sorry we ran a bit over. Okay, so let's see. A question from Arnold Liu. For the Lilly product, its high-dose combo seems to be more efficacious. Why is the low-dose combo selected for EUA instead? So that's I think that this was, that's a good question. My understanding is that the selection of the doses for the EUA, the lower doses, was in part also based on additional data that were submitted, looking at PK and perhaps virology. But it is unanswered as to, is there a difference really clinically between the higher dose and the dose that has been given, the doses that have been given the EUA. So we don't know the answer to that. Okay. So what about mAbs for PCR positive patients with mild COVID symptoms at high risk of complications, but who get admitted for other reasons? So actually, the EUA allows the monoclonals to be administered in that setting. All right. What is known about the effect of E484K and L452R on T cell response? I don't know. I have not myself seen literature on that, but I've also not searched. Okay. Should we consider dual monoclonal antibody therapy for immunosuppressed patients who are hospitalized with persistent infection? That's from Brandon Twardy. So that is an interesting question. And so we do have those individuals who have prolonged infection, ongoing viral replication, and it's actually thought that it's in those individuals that the variants may have emerged under persistent selective pressure. We don't have data on that, obviously. The data for monoclonals in the hospitalized setting did not pan out for benefit on top of when given in addition to remdesivir. Now, is there a role later? I really don't know, but that is an interesting question and perhaps could be pursued. Okay, and there were a few other questions received prior to the talk, and one was about speaking to inhaled budesonide. So there have been some more recent data on inhaled budesonide. A press release, I believe, from the Principal trial, which is a UK trial of outpatients, for therapies for outpatients with COVID-19. And in this interim analysis, there was reported a reduced time to recovery by a median of 3 days with inhaled budesonide, but I think one limitation is that that was interim data, and the study had not had, they didn't have a full 28-day follow-up for all the participants that were randomized. There was also a recent Lancet publication, Lancet Respiratory Medicine publication of inhaled budesonide phase 2 open label parallel group study where the inhaled budesonide was compared to usual care, not a more rigorous control in adults with less than 7 days of symptoms. And there, the primary endpoint was COVID-related urgent care visit, and that could include ED visits and hospitalizations. There were much fewer visits. Much fewer of that endpoint being met with budesonide. So I think more data are definitely warranted, more study needed. There do seem to be some hints of a potential benefit with inhaled budesonide. Okay, and then there's a question from Ryan Anson. If there were significant viral reductions using 2,800 milligrams of bamlanivimab, why do many clinical centers continue to use 700 milligrams prior to the recent treatment guideline change, as well as in the combination therapy? So that's because what is authorized by the EUA is the 700 and 1,400 milligram dose of bamlanivimab So it's really not an option to deviate from that dosing. But similar to the other question, I think there's still perhaps something to learn. We'll see what the clinical outcomes are with the current dosing. Okay, so here's another question from Glenn Wortman. There's been some supposition that the variants may be emerging in patients who receive plasma therapy. Oh yes, that's true. And I don't know if that's true, but any concern with this happening with monoclonal antibody therapy? So I think that there is theoretical concern that that could happen, that any of these antibody-based therapies could, in someone who had persistent prolonged replication or with suboptimal dosing, could exert then selective pressure and for variants to emerge. And so I think that is absolutely a theoretical concern. Okay, I think there are a couple questions that I think are asking about use of the monoclonals beyond 10 days of symptoms. And I've from the data and the experience so far, and also there's some nice data for prevention of symptomatic disease with very early monoclonal antibodies in the post-exposure prophylaxis setting or very early treatment essentially setting. They are kind of couched as post-exposure prophylaxis studies. I think that the data are really suggesting that the monoclonal antibodies need to be given very early for maximal benefit. So there are not data beyond the 10-day mark, but I think there would be significant concern that they would not be efficacious at that point, especially as at that point, if the real mechanism is a sort of an antiviral one, beyond 10 days, actually many individuals are no longer have detectable virus, and the antiviral benefit is likely reduced. Okay, we are at the end of the hour, and I want to thank everyone for their time and their questions. Sorry for the hiccups with the presentation earlier, but thanks very much. Bye-bye.
Thank you, Dr. Chu. As a reminder to our audience, evaluation on how to claim continuing education credits will be emailed by 5 p.m. tomorrow Pacific time, and that will enable us to review all those that have attended today's live program. Here's an upcoming list of webinars that we have. And to register, please visit the IAS-USA website. Additionally, here are the list of upcoming courses. We do have a course next Friday, April 30th. And to view our on-demand dialogues, please visit our website. Lastly, we'd like to thank our presenter, Dr. Chu, the audience for your participation, and all HIV clinicians working 24/7 to continue to provide care during the pandemic. This concludes today's webinar.